the time. And to kick off, I would like to respectfully acknowledge the traditional owners of the land on which we're meeting today. The Ngunnawal and the Ngambri country that we are on today is a place of respect that we can all acknowledge while we're here, and also respectfully acknowledge that many of us are here today from our rural and remote communities, and we also acknowledge the traditional owners on the lands from which we come from today, and our elders past, present and emerging. So thank you all. This really is a program today where we're speaking to our Allied Health Rural Generalist program about a place-based program. This is about supporting those who are working in country, in rural and remote regions, and really making a local difference and finding those solutions with their communities and for their communities. So today we will hear those success stories. This isn't about us being up here to preach to you, but very, very big thanks. These people have travelled to share their stories from a really long way today, so thank you. We do appreciate that. And those stories that we'll hear will speak to for themselves. They will speak about the impact, and that's what we want you to take from today. We will see that these programs are delivering on those programs and the priorities that our governments have identified and for what we need in our health systems. It is about supporting access. Having lived in a rural community for my whole career, this is about supporting those clients and those communities. I think it is also about enabling and supporting the health professionals to really work in teams and to do that independently and safely at that team and at that local level. It's also looking to support clinicians to work to that fuller practice. It isn't about being an allied health generalist worker. It is about working safely and working together with this rural generalist program to work to that full scope of practice. I think it's also about that local partnership and working with and guided by our First Nations people, and we're really thankful with our partners in supporting the model that we work in, and I'm sure the stories that will in particular come from Congress today will really highlight that for us. I think working together, this is about a rural workforce development for allied health, and if you feel the need to cheer and clap at this moment, please do, because it's an exciting time and it has been a long journey, so sharing that with us today. It is working together for that attraction and retention. This is about our workforce pipeline and helping to retain those who truly make a difference. So thank you for your time. And I believe I am now handing over to Minister McBride. I'm going to do it as you come up, give you a little thank you, Sarah tea towel. Now this is to make you all think about if you had an accident in rural and remote and you couldn't rehab because you didn't have the services, there wasn't the local allied health professional and that team around you, how would you wipe and dry your dishes? So that's just, for those of you that have a tea towel today, think about that as you're at home wiping it. It's about access to every one of us who might have to do the dishes at home. I have two OTs at the front here, so probably liking this story. Thank you, Minister McBride. I can take it to your table if you don't want to hold it. That's a gift for you.
Thank you very much. Thank you. Thank you very much, Lisa, for that warm introduction. I'd like to start by acknowledging the traditional owners of the land on which we meet and to pay my respects to elders past, present and emerging, and to extend that respect to First Nations people who are here today. And I just had a quick chance to meet AJ and Amy from Congress. And earlier in the year, I had the real privilege of coming to the Northern Territory and visiting Alice Springs and seeing what place-based local solutions with community control mean. You are genuinely making a difference, and thank you. But at the same time, acknowledging the sharp disparity in health outcomes of First Nations people, and despite the outcome of the referendum, our government's firm commitment to keep working together alongside you to close the gap. So thank you. I'd also like to acknowledge anybody here with a lived or living experience of mental ill health and those who care for and about them. With my responsibilities for mental health and suicide prevention, I know exactly the real impact that this has on the 7 million Australians living outside of our major centres, particularly in terms of access to timely care. I would also like to acknowledge my colleague, Dr. Helen Haynes, who has spent much of her career working in regional and remote parts of Australia, and now in the Parliament is translating that into policy and outcomes at a national level. So congratulations on the work that you've done. To the Services for Australian Rural and Remote Allied Health, for your advocacy and for the work that you're doing towards rural generalism for allied health. It is absolutely critical. And I mean, it's no secret that in Australia today, the further you live outside of a major city, the worse your health outcomes are likely to be. For a woman my age, living in the most remote parts of Australia, that gap in life expectancy can be up to 16 years. And that's not looking at quality of life. It's something that we're determined, working alongside you in close collaboration, to turn around. And I want to thank to Sarah and to all of the members and the clinicians and organisations that you represent for the work that you're doing each and every day in communities to bridge that gap. As has been mentioned by Lisa, what we're really here today is about success. And really showcasing that success. And from my experience as a clinician, as a pharmacist who worked in a regional hospital, I know that some of the best solutions are local solutions that are place-based, that respond to the particular unique needs and challenges of that community, but also lean into their strengths. Often rural and remote communities are spoken about in a real deficit way. And I think what we really need to do is turn that around, to really focus on those strengths, to lean into them, and to look at the innovation that comes from rural and remote communities. And that's what I'm so excited to be part of today, to be here to celebrate. And I wanted to let you know that as a government, we are firmly committed to working alongside you and to really focus on multidisciplinary care. We know team-based care is the right kind of care. And I've just had the chance to talk to 2 OTs who are based out of Albury but working an hour and a half outside of there about some of the work that they do and the flexibility that you need to have working in regional and remote communities to be able to work in disability, to be able to work in aged care, to work in different settings, and to be able to do that often within the course of, a day or across your week. So we know the versatility, the variety of work, but we also want to see that properly recognised. And that's why the government has launched our scope of practice review, because we want to make sure, it's called Unleashing the Potential, because we want to make sure that health practitioners can work to the full top of their skills and their training. But we also want to make sure that that's done in an environment where you have got the right kind of support around you, where you are genuinely part of a multidisciplinary team, where you work in an integrated way, where we've got the proper continuity of care. And then that's something that as a Commonwealth we take very seriously, which is why we've launched this scope of practice review. The first round of submissions has closed, and you'd be no surprise that there's been a lot of interest. And we'll be working in a nationally coordinated way to remove some of the legislative, regulatory and other barriers that impede clinicians from working to the top of the scope, that encourage them to work in strong collaboration, and that mean that each of you can use your full skills and training and expertise and knowledge working together for the communities that you care for. The other thing that I wanted to mention today as well was some of the particular work that we wanted to do around, first the focus on multidisciplinary care, but also the focus on really working in a much more, I guess we've spoken about multidisciplinary, but also to top of scope, but really looking at place-based solutions. And as I mentioned earlier, we know, and I've seen this in my own experience, that local solutions are often the most effective solutions. They're ones that are responding to the unique needs of a particular community, and they're responding in a way that draws on the strengths, the resources and the connections of those communities. And I think that that's something that we need to place a greater emphasis on, and I'm very mindful of that at a Commonwealth level and through the primary health networks. That often I'm told is that you talk about place-based, but the funding mechanisms are still very centralised, and there's not the same flexibility and responsiveness that we're after. This is something that we're very alive to and that we want to work with you so that we can genuinely look at where those pockets of success are, why they've worked, how they might be able to scale it up, and where they'll be able to benefit people elsewhere. I know that you're here today particularly to talk about the allied health rural generalist pathway, and as an allied health clinician myself, having that certainty of a pathway, that someone knows whether someone who's early in their career or someone who's more established in their career has a very clear pathway, knows what support is available to them, how they can access it, to be able to map out what they would like to do and see their career to develop. And we want to also to establish those ecosystems or those communities of practice, so that when you are practicing in those unique circumstances, that you don't feel isolated, that you have got that support around you to be able to succeed. And we also know, and I'll finish with this, that practicing in rural and remote communities, it's not just, I know that we have a shortage of health practitioners, but the greater problem we have is an uneven distribution of health practitioners. That most registered health practitioners or of the self-regulated disciplines, most of those clinicians live and work in our major cities. And this is a big challenge, but what we know or what we have seen or evidence tells us is that the best pipeline of rural and regional workforce is people like myself. Someone who grew up in a regional community, has chosen to live and work in that community. And that's why, as a government, we've committed to providing more support for Commonwealth supported places for doctors at rural medical schools, more scholarships for placement so that people can have quality placements, the opportunity for more end-to-end training so that someone can start from an undergraduate pathway, then have their early career and registration, and then continue within those communities or a community like that. So thank you for the chance to be here today on behalf of the government. Thank you for our ongoing engagement, Kath. It's to me, it's a real privilege to be able to work with people who are like-minded, who are in communities like the ones that I grew up in, that I work in, that I represent around Australia. And for those of you that I haven't met or haven't had a chance to work with properly, I thank you for the contribution that you're making. And I'm so keen today to hear about those real pockets of success. So thank you very much, Lisa and Kath.
So we're going to hear now from 3 examples of the work that we've been doing across the country to expand the allied health rural generalist pathway in non-government and private settings. So first up, we're going to hear from Hannah Mann and the Kimberley Pharmacy Service. So thank you, Hannah.
Excuse my nervousness. Before I begin, I would like to also acknowledge the traditional owners and custodians of the lands that we are on, the Ngunnawal and Ngambri people. And I live and work in the Kimberley, so I also pay particular respect to elders in the communities that I work in. I live in Broome on Yaru country, and just acknowledge that we all live and work on land that always was and always will be Aboriginal. So Kimberley Pharmacy Services stretches from Broome on the tip of the Kimberley all the way over to the Northern Territory border, so we cover an area twice the size of Victoria. So a reasonably large pharmacy-based service. Or how do I change slides? So we took a bit of a unusual, I guess, intake into the rural generalist pathway from a pharmacy perspective. We got involved in the pathway as a solution to a workforce crisis that we had in the Kimberley within pharmacy specifically, but wider within allied health. We got into a situation like a lot of other rural and remote areas where the solution to getting people in is to pay them more money, and then you have a worse outcome because you attract clinicians who are there for the money, not for the patients, and that is a slippery slope. So we really needed a way to recruit early career health professionals with a desire to make a difference in community and to want to learn and contribute, who were not just there for the money. And the pathway was the perfect solution to be able to do that for us. So we have rural generalist pathway pharmacists based in Broome, Horse Creek and Fitzroy Crossing, so our most remote pharmacy locations in the Kimberley, which I genuinely feel would not have been a possibility without without the support from the pathway. Can I change slides? Great. So this is Fitzroy Crossing, the first week of January this year, where we have a fabulous pharmacist called Mary Baker, who had just finished her pathway, having spent 18 months mainly in Fitzroy Crossing while studying, and was able to single-handedly manage medication supply to about 1,500 people in absolute crisis, and coordinate evacuations and medications in other regions, and work really well as a collaborative part of the healthcare team, which I think she did with the skills that she'd learnt through the pathway. She's an early career pharmacist, she's 25 years old, and that's an amazing piece of work, to work as part of a team where she is the only pharmacist in that town, or was at that time. So I think it's a really important example of the success of a pathway graduate being able to work as an independent practitioner in a crisis situation and really deliver exactly what the community needed. I just thought this is the pathway, but I just wanted to have a quick chat about service development, because that was a key thing in discussions with the wider healthcare region in the Kimberley that everyone wanted. We had all of these pieces of work that were really important that nobody had time to do, and they crossed over multi-professions. So it was developing resources. The pathway pharmacists this year are doing a 2-year respiratory health project, which they are leading, which I think is an amazing situation where we have a generalist skill set. We have pharmacists writing lung health protocols and leading spirometry and education for Aboriginal health practitioners in the lung health space, because they are developing a generalist skill set and becoming a really respected member of the healthcare team. So the service development component, I think, of the pathway is really critical for rural and remote areas. It's how we move everybody forward, and it's how we're going to work towards closing the gap. So quick thing around, I guess, the changing landscape. So the pathway, I guess, looking forward for rural and remote pharmacy practice, we have some big things coming down the line, which are going to be very challenging for us. And one of those is aged care and patients choosing to age at home. Really difficult in a rural and remote area. Those patients need a lot of allied health support. NDIS, obviously, scope of practice is a big one, with expanding scope of practice for pharmacists, particularly in rural and remote areas. Prescribing by non-traditional prescribers, so that's allied health, physios, pharmacists, Aboriginal health practitioners moving into more of a prescribing role. And these clinicians are all going to need the support of a structured sort of workplace environment. And the shared employment model. We use the shared employment model for the graduate positions in the Kimberley. So that is grouping together organisations like aged care, Aboriginal health services, our state-based hospitals, and private businesses like mine, and creating positions for pathway pharmacists, where they work across all different, the single employment model. They work directly for Kimberley Pharmacy Services, but contract back into the other service providers as well. So Derby is a town of about 6,500 people. We went from a single pharmacist to 2 pharmacists, and that graduate pharmacist position provides clinical services into the hospital, which at that point had no inpatient clinical pharmacist care, despite being a 20-bed hospital. And also work across aged care and the Aboriginal Health Service, Fitzroy Crossing. We went from 1 pharmacist to 2 pharmacists, and again, we're providing clinical services every day on the ward of a hospital that had never had a clinical pharmacist work every day in the hospital. Horse Creek, we now have a full-time embedded non-dispensing pharmacist in the Aboriginal Health Service, which is also supporting the aged care now as well. And in Kununurra next year, we have a new position working with the Aboriginal Health Service as well. So using the pathway to create positions so that clinicians can work across many different areas, and young early career pharmacists and health professionals say all the time that they want variety, they want flexibility, they want to work across many different areas, they want to increase their scope of practice, and the pathway, I guess, for us has been the lever to be able to do that. So just wanted to say partnerships work, and small businesses in rural and remote areas are definitely not the enemy. We're often the beating heart of our communities, and we can really lead in shared employment models. We really need to plan for the allied health demand to support people ageing and dying at home. This should not be a privilege of people that live in the metro area. We need to support people in our rural and remote communities to have equitable access to allied health at their end stages of life. We need to provide allied health services to where people are, not where they, and not expect patients to come to us. So the pathway for us was about increasing workforce and also supporting those single clinician-based service providers to be able to add an additional clinician to their service model, just to create a viable and strong workforce. That is all from me. Thank you.
So, thank you, Hannah. That was a whirlwind trip through quite there was a dense amount of information in there, and we do have a few minutes. So, does anybody have any questions for Hannah at this point?
Yeah, I'll jump on it. Oh, sorry.
Oh, you go.
Just around the recruitment, Hannah.
Yes.
The pathway has given certainty, you say, to early career practitioners. I'm from the Australian Pharmacy Council, so I do have a bit of a relationship there. So how attractive has that been to gaining workforce, which I know has been so difficult for you?
Yeah, so 2021, 2022 was 3 additional pharmacists, one of which, so 2 finished the pathway. One works now in rural Victoria, and the other one has stayed in the Kimberley and is working at Fitzroy Crossing. I have 2 current pathway pharmacists, which I was able to recruit because of the advertising. And, I think when you advertise and you include the pathway in your ad, you attract a very different type of health professional than just saying, come and work in Broome, here, have a beach. It's nice to be able to say there's all of these other things that we can do for you. So we've got 2 pharmacists this year, one of which has already asked to extend for 4 years, which is amazing. So I think for us it's about getting clinicians in. I think it's also changed the dynamic for my senior pharmacists as well, who now have mentoring and education opportunities for their own professional development to be able to feel like they're contributing to the new generation of pharmacists coming through, because we have we have a structured program, we have structured time every week for project work, and I think that really changes the dynamic across not only all of my staff, not just the pathway pharmacists coming through.
I suppose on that workforce front, the diversity is the clinicians that you've employed reflective of the communities that you serve?
We've done a lot of recruiting externally. We are yet to have a local Aboriginal pharmacist in the Kimberley, which makes me a bit sad, but in 2 years' time we will. So we have a pharmacist, a woman from Horse Creek who is studying pharmacy right now, who's very keen on doing the pathway as soon as she finishes university, and will come to Horse Creek and be the full-time pharmacist in the Aboriginal Health Service there, which is, I guess, the end goal really is, trying to do some homegrown pharmacists in the Kimberley rather than always externally recruiting.
Fantastic. Thank
That's
you.
huge, I've just got to say. I'm going to say, just anyone who knows anything about the Aboriginal and Torres Strait Islander allied health workforce knows that the growth rate has been ridiculously slow, and that's not through lack of effort from the various bodies concerned, but so groups like IHAR and others have really done a lot there. But I think if we're going to go anywhere near growing the workforce to the extent of that workforce plan every government's committed to, it's groups like Hannah, and we've just got to build it everywhere. That's a fantastic example.
Well done. Okay, so that brings us to our next presentation, and while AJ and Amy are getting mic'd up there, we are going to hear now from the Allied Health Generalist Podiatry Service in Central Australia. I will allow you guys to explain the rest.
Werda, everybody. My name's Andrew Jolly. I'm a non-Indigenous man living in Central Australia, Central Aranda country, in fact, in a place called Mbanta, otherwise known as Alice Springs. It's my pleasure to stand alongside Amy and meet with you all today as an employee of Central Australian Aboriginal Congress, and I'm the Allied Health Manager. I tried to get Amy to speak first, but she just wouldn't let me have it, so you got me. I'd like to acknowledge that we're meeting today on the lands of the Ngunnawal and Ngambri people. I pay respect to elders, past, present and emerging. I'd also like to extend my respect to any Aboriginal and Torres Strait Islander people in the room today. For 50 years, Central Australian Aboriginal Congress, or Congress as it's known, has provided support and advocacy for Aboriginal people in the struggle for justice and equity. Since that time, Congress has expanded to become the largest Aboriginal community-controlled health organisation in the NT, providing a comprehensive, holistic and culturally responsive primary health care service. This service is provided to Aboriginal people living in Mbantua and surrounding remote communities of Amungana, Ndari, Galtagajara, Gingerporta, Uchu, Amampa, Yalara and Mutijulu. Today, Congress is one of the most experienced Aboriginal primary healthcare services in the country, as a strong political advocate for closing the gap for Aboriginal health disadvantage and a national leader in improving health outcomes for Aboriginal people. Under the governance of, leadership by and collaboration with Aboriginal community members, Congress's allied health program has expanded. In 2021, we went from 10 positions to 33 this year, full-time equivalent roles. This expansion is necessary as a response to the community-identified need to address health disparities affecting Aboriginal communities in Central Aussie, with a focus on combating the high incidence of chronic disease. As of today, 40% of Aboriginal adults in Central Australia now live with a diagnosis of diabetes. Integral to the expansion of Congress's allied health program, the Allied Health Rural Generalist program has played a pivotal role, a pathway I should say. The pathway's design recognises that allied health professionals in remote areas are tasked with the dual role of delivering and developing services. 5 Congress allied health professionals have participated in the Allied Health Rural Generalist pathway and initiated meaningful service development projects, all of which are now sustainably embedded into our usual business. We see that sustainability of these projects is attributable to Sarah's support. Sarah's, sorry, I got told off for saying Sarah. No one told me off, but apparently that's the right pronunciation, which enabled dedicated time, training and resources to make sure that these service development activities are sustained. In the healthcare workforce crisis following COVID, the opportunity of an allied health rural generalist pathway has bolstered our recruitment and retention efforts, helping to attract people to these necessary roles. AMY's Allied Health Rural Generalist Pathway participation has seen the implementation of a project in response to community feedback that an alternative was needed to high-risk foot care in a hospital setting. We'll hear from Amy about that next. Other Congress Allied Health Rural Generalist Pathway alumni have contributed by initiating community-based falls prevention group known as the Deadly Wobblers, a community chronic disease rehabilitation group in a partnership with Alice Springs Town Council and the Town Pool. We deliver a women's cook-up initiative at Congress's women's only Aboriginal health clinic known as Alukra. And we've also recently completed a project that has investigated the reasons for missed appointments using a non-judgmental framework. Beyond project success, the Allied Health Rural Generalist Pathway has strengthened our team by connecting our allied health professionals with mentors nationwide. And this has reduced the professional isolation associated with being in a remote setting as Central Aussie. The structured supervision and professional practice standards set by the program are benchmarks we aim to extend to all staff in allied health and across the primary healthcare service. I'd like to also recognise Sarah's thoughtful design of the Allied Health Rural Generalist Pathway program, which has made our implementation really smooth. In a context where funding streams for primary health care are complex and diverse, this is especially appreciated. Congress's collaboration with Sarah has opened doors to additional supports towards building an Aboriginal allied health assistant workforce. Within Congress and the Congress Allied Health team, we've created 3 Aboriginal AHA traineeship positions. Sarah's program support has enabled us to design an Aboriginal AHA traineeship framework with key input from an Aranda Aboriginal allied health cadet. Congress's commitment to placing Aboriginal health in Aboriginal hands is our highest priority. Reflected in this is our focus on a sustainable employment pathway for Aboriginal people in key professional roles. Alongside AHA positions, the Allied Health Rural Generalist Pathway, in this context, is a vital element in the educational continuum for building this workforce. Congress is rooted in a community-controlled approach that prioritises Aboriginal ways of knowing, doing and being. The Allied Health Rural Generalist Pathway provides a platform which has facilitated meaningful projects to put this ethos into practice. We see a bright future for the Allied Health Rural Generalist Pathway and hope that the principles of empowerment for Aboriginal and Torres Strait Islander people through community-controlled mechanisms be an integral and important part of the pathway going forward. We'd like to see that allied health teams within Aboriginal community-controlled health organisations around Australia can continue to grow and continue to build pathways which privilege Aboriginal ways of doing and an Aboriginal workforce. Thanks for listening in. Right.
Yep. So, hi, I'm Amy. I'm a podiatrist and I'm not a public speaker, so please bear with me. I work at Central Australian Aboriginal Congress, better known as Congress, and in Mbantua, Alice Springs, home of the Aranda people. Firstly, I'd like to acknowledge the traditional owners of Canberra, the Ngunnawal people. I am a part of the Sarah Rural Generalist Pathway program, and with this, I was able to create a multidisciplinary high-risk foot clinic at Congress. Evidence shows that best outcomes for those living with a diabetes-related foot wound are achieved when multidisciplinary and coordinated care is provided. However, this type of service is often only available in a hospital setting. The Rural Generalist Pathway allowed me to undertake a project to start a high-risk foot clinic at Congress. There are national standards for multidisciplinary high-risk foot clinics, and I was able to perform a gap analysis and develop referral pathways and documents to support the process of accreditation against these standards. So my vision for the high-risk foot clinic was for it to be embedded in an Aboriginal community-controlled health organisation. This creates a culturally responsive space for clients to access healthcare. The clinic commenced in mid-2022 and now runs weekly on a Tuesday morning, where clients living with active diabetes-related foot wounds are provided a joint appointment with a podiatrist and diabetes educator. There is a GP on call if needed and defined referral pathways to the hospital and other specialist services such as a vascular surgeon. Many of our clients living with diabetes-related foot complications attend renal dialysis 3 days per week, in addition to attending specialist appointments, seeing the GP, diabetes educator, dietitian and many other health professionals that help reduce the impact of diabetes. This clinic enables clients to see multiple health professionals in one appointment, thus reducing their appointment burden and time spent at the clinic, and it has enabled more time for cultural and family responsibilities. One of my main roles is coordinating people living with diabetes-related foot wounds to ensure they are receiving care. This is a time-intensive process that comprises of file reviews, checking my health record, or completing referrals to our Aboriginal liaison officer. We frequently use an ALO to help locate clients in the community and transport them to our health service to access care. Accompanying the high-risk foot clinic are linkages to a regional telehealth podiatry service provided by Congress. This service is coupled with diabetes foot resource kits in all 32 remote community clinics in our region, covering a service area of over 1 million square kilometres. Because of Congress's podiatry service, clients can access care close to home, whether in a remote community or in town, with coordination support from the telehealth service. One story comes to mind. A client has been discharged from an interstate hospital and I noticed that they hadn't accessed services recently. I was able to complete an ALO referral and see them the following day at the high-risk foot clinic. The client was able to see the diabetes educator, myself, the nurse and the GP. In that appointment, we were able to coordinate medication scripts, complete wound care, take bloods, review the discharge plan and complete outgoing specialist referrals. The clinic is truly a one-stop shop. Over the last 18 months, the clinic has achieved improved health outcomes for people living with diabetes-related foot complications, increased access to diabetes educators and strengthened referral pathways to the local tertiary hospital. The now established multidisciplinary high-risk clinic has been able to deliver tertiary level healthcare in a primary healthcare level under an ARCHO. For the last 5 months, there has been no podiatrist at the local tertiary hospital, and this clinic has been able to fill this void when workforce shortages impact our community. More broadly, the podiatry team and our allied health team have benefited from the pathway, as we can see the impact these service development projects have had on our workplace, peers and clients. The gap analysis process has allowed us to reflect on our service delivery and prepare pathways and procedures that are in line with current international guidelines. This ensures that we are staying up to date with best practice and learning from the colleagues and clients we are working alongside. Since commencing the pathway, I've been able to participate in further education, gain postgraduate experience within a rural and remote context, become a more well-rounded clinician by expanding my scope of practice, and participate in structured mentoring and supervision. Gaining this experience allowed me to progress my career into a leadership role. I'm incredibly proud of my project and the benefits it has brought to our community. I credit this to the dedicated time Sarah has allowed me throughout the Rural Generalist pathway.
Thank you, Ray and Amy. Fantastic presentation. So does anybody have any questions? Al?
Very quick one. Has there been any sense, and I would have counted this, but there must be people who have kept limbs as a result of this service that would have otherwise lost them. Do you have a rough guess of that? Sorry.
Oh, I don't have any data or anything. I guess just anecdotally, like we've definitely, helped escalate people to hospital to get treatment or build a relationship at an art show, and then I can accompany them to the hospital at the Surge Foot Clinic, and that's how building that relationship between tertiary and primary is really needed, and that's where we're bridging that gap.
A quick comment too, we did a bit of research around this a few years back and could see that the lower limb amputation rate and the incidence of lower limb amputation associated with diabetes was the highest for any region in Central Australia. So it's a significant problem. And this was prior to, I guess, some of the services that Congress and Amy's been able to implement, the telehealth, the high-risk foot clinic, etc., the offloading kits in remote communities. We've just heard from the hospital to say, Alice Springs Hospital that is, to say they're going to do another follow-on of that same project. So we'll be able to compare the before and after. So we don't have the data yet. It's a pretty hard piece of information to crunch. Or maybe it's a bit simple. We'll see what the numbers look like. But we're really hoping that there's an impact.
It's always hard to count, but what people say you think it is.
But that sounds like a paper for the conference next year.
Cool. Yep, sign us up.
So thank you. Thanks very much. And now I'd like to introduce Sabrina and Meg from iCarrier Health. So guys, over to you.
Thank you. Hi, I'm Meg and this is Sab. I feel like we've met a fair few people in the room now, but for those who haven't had the chance to meet us yet, we're from iCarrier Health based in Albury-Wodonga. However, Sab and I work and live rurally in our respective communities. So myself, I'm in Holbrook, which is 40 minutes north of Albury-Wodonga, and Sab in the Berrigan region, which is an hour and a half northwest. We're currently completing the Level 2 pathway, which has enabled us the opportunities to develop our service projects aimed at improving health outcomes for our local people residing in our unique communities. I work predominantly in the paediatric space, whereas Sab works mainly in the adult NDIS and aged care. So individuals living in rural and remote Australian communities do not have the same access and choice and control to health services as those individuals living in the metro areas and regional cities, as the presenters before us have spoken about. Prior to commencing the rural pathway, I was living in a rural community but travelling to Albury, a regional city, for work. These health disparities only became apparent to myself when I attended the local IGA in my work uniform. I had many people on many occasions come up to me asking if I worked rurally and in the area and if I had capacity to see one of their family members, friends, so on. Many individuals told me of their stories about being on wait lists for 12 months or more, or having all of their therapy funding being spent on the therapist travel rather than actually getting to see the therapist. This made me want to provide an accessible OT service for my community and reduce these disparities between rural and remote individuals.
Like Meg, I'm passionate about living in a rural community because of the health inequities for the members, but also because it's a great lifestyle and a great place to live. The Berrigan Shire has been my home and place of full-time work for the last 4 years now. During this time, I've constantly wanted to learn how to understand the unique needs of the community and align our service with those needs. It hasn't been until this year, 12 months into our pathway, have I truly felt that I've been able to learn and work towards this goal. My service project aims to improve pressure care for education for residential aged care staff. The inspiration for this came from the local facility requesting support to reduce the number of pressure injuries within their facility, as they'd recognised they were above national average. Being a rural and remote facility, difficulties in addressing this issue were exacerbated by limited access and retention of well-trained staff, and for many staff members, English was their second language. So staff needed a safe place to learn, to upskill, clarify roles and responsibilities, and to ask questions. A pressure injury is a preventable condition which can be excruciatingly painful, potentially life-threatening, expensive to manage, and most importantly, cause significant negative impacts for a person's quality of life. In 2020, the Royal Commission into Aged Care Quality and Safety found per every 100 residents, there were almost 7 observations of pressure injury. This is significantly concerning as pressure injuries are a preventable condition. My project involves an interacting education session for staff to increase their understanding, effective prevention and management for pressure injuries, meaning better health outcomes and improved quality of life for those older people residing in these facilities. And the next one. So how will this benefit aged care? So improve quality of life for the residents, improve staff education, promote allied health within aged care settings and therefore enable specialised knowledge and evidence-based supports, reduce the strain on existing staff, support effective prevention management and reduce the number of pressure injuries within facilities. Through the sessions I've completed thus far, at one facility we were able to recognise there was a misunderstanding regarding best practice and some equipment. This enabled the facility to update their policies and procedures and in relation to evidence-based mattresses for pressure care. Floss was an 84-year-old lady who was experiencing excruciating pain due to bilateral pressure injuries on both heels. The change in equipment enabled her injuries to heal, and which relieved her pain and improved her quality of life. This is just one example of many. As part of my project, I hope that these sessions can be provided to many residential aged care homes in our region and continue to make a difference in many lives.
That's what Holbrook is known for, anyone that hasn't driven through Holbrook. We have the big submarine. So my service delivery project is to deliver an OT service for the Holbrook and surrounding communities. This was something I was wanting and hoping to do prior to commencing with the Rural Generalist pathway. So when the opportunity arose, I was immediately interested. Commencing the pathway has enabled me to work closely with local community members. One lady, and her story really resonates with me, shared her personal experience of accessing healthcare and the cost of living rurally. She reported the burden on her husband to support her to travel to medical appointments, the financial cost of travel, and how having to sit in the car for 2 hours in the day significantly exacerbated her levels of pain. Consequently, the following 2 days post-travel, she was unable to participate in social or leisure or domestic tasks. This negatively impacted her quality of life and also increased the caring role of her husband. The aim of my service delivery project is to reduce these disparities for individuals like my client living rurally and therefore promote quality of life. The Rural Generalist pathway has enabled us valuable learning through the JCU coursework, mentoring and supervision, and other additional learnings through the pathway, providing us with the resources and skills to assess the needs of our community and ensure a sustainable and effective service is developed. This has enabled us to have time away from our clinical caseloads to develop our service,
meet with community members and build professional connections on the ground levels in our communities. This has provided our communities access to highly skilled clinicians with the generalist skill set. Without Sarah, we would not have the resources and opportunities to develop our projects and support our communities based on their needs and in a sustainable way.
Both projects are based on community needs and involve strong community voices and representatives. This pathway has enabled us to confidently build on existing connections within our home communities and make big differences. The fact that Meg and I are part of our communities means that we know the individuals, the community groups, and we have and do experience the same inequities that they do. This enables trust, enriches connection, and contributes to better health outcomes, thus far of which is hard to establish for drop-in, drop-out services who don't always understand the unique needs of a community.
Something Sab and I often talk about is how we both enjoy living and working in our communities, as it provides us with a sense of ownership, and we feel as though this is also reciprocated by our clients. We know the local services, support groups and organisations to connect our participants with, without them having to travel to feel the needs of being connected. The community also gets to see both of us as people and not just their healthcare professionals. Seeing us both play at our local netball clubs, running into one another at the shops, or giving me a wave as I'm out walking my dogs. This has supported me to build the rapport and reduce the barriers and fears that may be present with individuals accessing healthcare due to potential mistrust or adverse experiences previously with accessing healthcare.
We love and appreciate the same things our community does, like being able to say g'day to everyone down the street, talk about the footy scores from the weekend or about the weather for the farmers. Having opportunity to connect and participate on such a level is not something every clinician is fortunate to experience. Sarah has not only enabled the development of our projects and improved services for our communities, but it has allowed for valuable learning of which can ensure the sustainability of our rural services and passion for rural health. Thank you to Sarah for enabling us to learn and become rural generalists and provide these services to our communities. Thanks.
Thanks, everyone.
Thank you. It warms my heart hearing stories like this. Does anybody have any questions for Sabrina and Meg?
Sorry, guys. How many aged care facilities are you in at the moment with your project?
Yeah, so we're only really early stages. I've done 2 at the moment, but I'm getting some feedback from some other OTs within our service and developing the presentation a bit more, and hope to connect with more facilities. Yep.
And Sab's kind of getting that service up and running and hoping that I might even be able to transition to the Holbrook area.
Yeah.
In the near future, hopefully as well.
Yeah. And hopefully more therapists within our, company as well might be able to, develop those services and offer them to others in the region as well.
Yeah.
Because I think it's important to note too that Peter, your managing director, is actually a gerontologist physiotherapist. So his special area is aged care.
Yeah.
So I think this is certainly setting some foundations for the future. And I know, Jenny, you may be able to provide a little bit more detail, that many of the service providers we're working with, who may have a basis that was built around the NDIS, are starting to look at and explore options to expand into aged care. So this is certainly, again, setting some foundations to enable supports to be delivered into rural and remote settings.
Thank you.
So, in addition to, part of the arrangement, part of the funding that we've had was to develop some practice support. So, if you could just flick through to the leadership slide, thank you. I'll just fast forward through some of these. What we had identified is that, in addition to the supports we were building for trainees, that the service managers and supervisors were also providing feedback to us saying, for example, well, I haven't done anything around project management. You know, it's not necessarily part of an undergraduate program, and so so one of the first things that we did was build a project management online course. We were fortunate in that Gemma has background in that area, as did Rhiannon, who was one of the early project managers with us. And so we built on their expertise to develop something that was quite bespoke for allied health professionals in a health setting. So, can we back it up a bit? Thank you. So in addition to that, and obviously alongside of the allied health assistant work that we're doing, and I won't dive too much into that, back again, so it's that one. So the allied health assistant piece, we needed to develop a resource to help services think about how they would rearrange the way they deliver services to accommodate allied health assistants in their workplace and how allied health assistants might be delivering services. So we also have fairly extensively built a program that enables those and provides guidance to services to redesign the way they deliver services to accommodate an allied health assistant. And so in the National Allied Health Conference that was delivered in Perth recently, we ran a workshop. Gemma and Shem and Bonnie and Sylvia all led that piece that opened up the project supports to a wider audience. So we provide it to the training participants, but this also gave some feedback and some resourcing to people who might be considering coming on board with the Rural Generalist program to think about what they needed to do. In addition to that, we've started to look at leadership. So recognising that we are looking at the leaders, the current and future leaders of the allied health workforce, what can we do to support the development of leadership, which is somewhat different to a clinical capacity. It, in some respects, looks at some of those soft skills and stepping away from your technical expertise to be able to understand what is needed to develop a service or work with community. So we set up a partnership with the Australian Rural Leadership Foundation, whom we would consider the gold standard in leadership programs that are available. Their program is a 15-month fully immersive program. What this is a bit of a taster, a stepping stone. So it's a 7-week program that is tailored around the needs of allied health professionals. So we now have over 150 people have gone through that program now, including Annie over here, and probably others in the room. Who else in that room has gone through the leadership program? AJ, yes, of course. So 150 people networked across the country who have, considered their leadership role within the service that they're providing, which is pretty powerful stuff. So it looks at things like engaging with others and understanding the networks of influence that support and enable leadership, developing the leadership skills and devise clear pathways forward, developing the skills needed to advocate and contribute to broader conversations concerning health delivery and outcomes in rural and remote areas. Next slide, thank you. So the next stage is then looking at mentorship. So as we are building this network of leaders, how do we support those early career graduates coming through the system and address some of those issues around professional isolation? So I won't go too much into the model, but and this model is readily available. It's not bespoke for allied health, but it's the framework through which we are establishing a mentoring program. And so through our resourcing, we will have allied health professionals who will be both mentors and mentees. We take it from a perspective that you don't need to be an experienced clinician to be a mentor. It is about creating a safe space to enable conversations to happen and to explore topics that are, of interest to the mentee. So it's not that mentee is sitting at the feet of the experienced wise sage. It is a peer, peer-to-peer relationship. Thank you. So this is, so our next phase is about our digital platform. So how do we enable this network that we're developing to connect with each other so that it's not so dependent on us, although we do need to be involved. But how do we grow and connect people who are engaging with our coursework through our programs and learning from each other? So the circle space is enabling that capacity that we need as an organisation so that people can engage with each other and learn from each other. So I'm not the expert on this, so I'm not going to spend too much time on it. Thank you. But it does expand our networking capacity beyond anything that we've done before. It's still, we've done a soft launch so people can get in there and engage and look around. And we are still kind of working through, how we can best administer and moderate this system. But it enables project participants to have their own spaces so that they can engage with each other and learn about what they're all doing, because, I'm looking at these people who've probably not met each other before today. And so this is enabling those connections to be made. And it's going to be a really rich environment as we move forward. Next slide. Oh, and there's some familiar faces up there. So one way that people can connect and also share their stories with each other is through the open discussion space. And this aspect of our education approach to share story is the foundation of our work. It is the voice of rural and remote allied health that has the potential to shape allied health in the bush. Next slide. So, that is the map of Australia. So what we've done is you're going to see how we are building this network. So the next slide, thank you, is those people who have completed their project management course. So what you see there is their location, and you probably can't read it, but it's their discipline. Pretty much well spread across the country. There's some work to do in Tasmania. So the next slide is our allied health assistant model of care. So you can see how we're building the spread and the service type across the country. If we go to the next slide, you'll see that this adds in our leadership program. And then if we add in the Allied Health Rural Generalist program, you can see how we are starting to really flesh out these areas in Australia that are underserviced in most regards. So these people are making the difference. The important thing about this is that we've engaged with, this is Mel's figures, I'm just a bit astounded by this myself, 3,000 odd people in the Sarah network. So about 1,000 of those are members. So what a fantastic tapestry this is becoming and this is building. And it's this connected network that is the key to future developing capacity in remote and rural allied health. It's about using the available technologies in the best way possible. I think that's it. So the last slide is, we are going digital, and there is a whole lot more to come. So these are just the building blocks, but I think that gives you a sense of where we're heading with it all. So thank you very much. All right, and so I think that's...